I now call upon Dr. Minu Mathan to present Dr. SUVIRA JAIN's talk on anterior capsulorhexis tear and how to proceed with surgery.
Where in the anterior.
No, she could not make it today, but then she has made a very good film with voiceover covering most of the topics regarding the unruly anterior capsule. So let's watch this. Thank you, Amit. So let's watch this.
The capsule was torn and the ways in which we managed them. This is a case with a fibrosed anterior capsule. Now, fibrosis of the anterior capsule results in erratic tears in the anterior capsule. This patient, you can look at the extensive level of fibrosis, and when the surgeon is trying, with the help of a uterus forceps, to pull on the anterior capsule, there's a tear that goes out to the periphery. The fibrosis in the path of the tear may also limit the extension further into the periphery. Unable to proceed further, the surgeon actually picks up the anterior capsule at the other end, thereby attempting to complete the rhexis from the other side. Unable to proceed further, the surgeon needed to resort to intraocular scissors to complete the tear in the anterior capsule. Let's move to the next case where there is an iatrogenic Argentinian flap tear. In this patient with a dense nuclear sclerosis and a small pupil, at the outset the surgeon puts in a malleugent ring to achieve pupillary dilatation. Following this, we start with the capsulorhexis. The initiation of the capsulotomy seems okay, and as the rhexis is progressing, see what happens at the 7 o'clock position. There seems to be a tear that seems to be going out towards the periphery. The surgeon attempts with the capsulotome to bring it around, but that doesn't work. Under a viscoelastic cover, the surgeon then introduces a uterus forceps, holds on to the torn anterior capsule closest to its edge, and starts to pull inwards. While attempting to pull inwards, he uses so much force that the tear actually extends to the other side at the 2 o'clock position. So now we have 2 tears in the anterior capsule that have extended out towards the periphery. The uterus forceps is now reintroduced and the surgeon just pulls on the anterior capsular edge and draws it in to complete the rhexis. Following a gentle hydrodissection and under a dispersive OVD cover, the surgeon then proceeds with the phacoemulsification. The technique to be used is a horizontal chop with a limited lateral separation. Extreme care and caution is used throughout the surgery to make sure that we limit the extent of intraoperative manipulations. And the one thing that gets us by in this case is the fact that the surgeon continues to do a viscofluid exchange at every step during the case to prevent a shallowing of the anterior chamber and therefore an extension of the tear into the periphery. In this next case, the surgeon had an accidental injury into the anterior capsule, resulting as what you can see, a tripartite tear in the anterior capsule. Please note that at the 2 and the 5 o'clock position, it doesn't seem to have extended to the periphery. Let's see how we manage this case. Under the cover of a viscoelastic, with the help of the uterus forceps, I hold onto the torn edge inferiorly and pull in an anti-clockwise direction and continue in this manner till it meets the proximal tear at the 11 o'clock position. With the help of a cystotome, I then make a nick in the capsule at the 7 o'clock position, hold on to that tiny tear now created, and repeat the exact same procedure. In this exact same manner, the tear is now extended in the remaining part of the capsule. Let's now move to the next case where we have a rhexis tending to extend again to the periphery. In this case, you'll see that the initial part of the rhexis seems to be going fine. So also halfway down the rhexis, everything seems okay. However, when the surgeon then propagates the tear proximally and gets to the subincisional part, see what happens. On taking a closer look, we found an extension of the tear in an outward direction. This torn edge was then held with the help of a uterus forceps and we tried to propagate the tear. But alas, this attempt resulted in a rhexis runoff to the periphery. Under viscoelastic, we evaluated the situation once more and decided to perform a Little's maneuver. We flattened the anterior capsule and from the opposite direction, a uterus was now introduced. We held on to the torn edge at its extreme periphery and we pulled in an inward direction. This centripetal force resulted in the capsular edge being pulled towards the center and rejoining the original rhexis, and therefore giving us a complete stable rhexis. In this following case, let's visualize now how this tear in the anterior capsule occurs during hydrodissection. This is a patient with a lamellar cataract, and as you can see, the capsulorhexis seems to be uneventful. Right at the end, notice how the surgeon goes back in and holds on to the rhexis and brings it in. While attempting hydrodissection, see what happens. There's a sudden rip in the anterior capsule at the 9 o'clock position. Perhaps there might have been a tiny tear. Perhaps there might have been an accidental nick in the anterior capsule during the last step of going back in, hooking onto the rhexis and bringing it inwards to complete it. After introducing some viscoelastic, I attempt to perform a phaco. It's a very soft cataract, so the only aim is to not do any kind of lateral separation, reduce the manipulations in the eye, and virtually hold on to the nucleus, bring it up, and aspirate it, which is what I did. At this stage, the crucial step is to perform a viscofluid exchange. Whilst performing the viscofluid exchange, you're going to negate the chances. During irrigation aspiration, you need to take utmost care when you're actually pulling on the cortex in the area of the torn anterior capsule, because you don't want to accidentally hold on to that anterior capsule, because that could result either in the extension of the tear or in a zonular dialysis. It is imperative to perform a viscofluid exchange before swapping hands during irrigation aspiration. The remaining cortex is removed with care and caution. We perform a viscofluid exchange, then introduce the IOL and do a visco wash and hydrate the wounds, and this is the end result that we achieved. In this next case, the surgeon has accidentally nicked the anterior capsule while making one of these incisions. This is what the tear in the anterior capsule looked like. The challenge in this case would be starting a tear and then trying to propagate it. So under an OVD cover, I introduce a cystome from the opposite side and make a little nick. Thereafter, I hold it with a Utrotas forceps and pull on the anterior capsule to create what looks like a tear. I then re-enter from the left side and push this tear and propagate it further. Holding on to the bent capsule and pushing ahead, I'm able to, in this manner, complete the rhexis. You will now notice that you do have an intact rhexis, however, it is eccentric. Therefore, it is now enlarged. In order to do so, I make a tangential nick in the anterior capsule, hold on to that tear, and enlarge it suitably, thereby giving me a resultant opening, which is comfortable to perform safe phacoemulsification and the implantation of an IOL in the bag. This is the last case that I will discuss, which is a surgery abandoned by a previous surgeon during rhexis. And this is how he presented to us. You can see after staining the capsule, I could see the obvious tear in the anterior capsule. I held on to it with the help of a McPherson's and was able to just pull literally with some force towards the center, and I managed to convert this tear into a stable rhexis. With this, I come to the end of my presentation.